But yeah, it's trying to let people know we don't think of you as a bad person because you got something for pain. That doesn't make you bad. That makes you human.
Hi, everyone, and welcome back to Harmonia Podcast. Today, we're joined by Dr. Vicki Williams. She is an amazing rehab consultant and medical cannabis prescriber. Hi, Vicki.
Hi there, Berta. Thank you so much for having me on.
No worries at all. Thank you so much for coming on. Would you like to give a little bit of an introduction?
Yeah, sure. So I know you've introduced me as a rehabilitation consultant, and I suspect that the majority of your listeners won't know what that is. So, the way I describe it to patients is that, in a nutshell, I manage patients with disabilities. For me, particularly neurological ones, but also musculoskeletal. There's quite a wide variety of different obviously disabilities, but that's what basically we do in rehab medicine. Our goal is to give patients the best quality of life that they can possibly have, and it's a very, very holistic approach to patient care. So, whereas I think a lot of specialties will kind of focus on one organ system or one particular issue, we kind of have a very global look at a patient. And I'd like to tell my patients by the time I finish, a couple of consultations with you, I will know your financial arrangements. I will know what your sex life is like. I will know just about everything about you, because the idea is that if I add or take away anything into that mix, I can hopefully predict what the end result will be in you globally as a person, rather than looking at a specific organ system and saying, well, let's just fix that. Instead, we try and look at the impact on the entire person. So it's quite a different specialty. I love it. It's a lot of team based working. You're often with OTs and physiotherapists and speech therapists and psychologists. So it's not kind of just about the doctor. As I said, it's just such a holistic way of approaching the patient, which is what I absolutely adore about it. So that's kind of where I've come from. I've been a consultant now for 7.5 years, and in that time I've kind of obviously been in the NHS for quite a while, but then gradually transitioned to incorporate cannabis prescription into my practice over the last year or so, and just been really interested and excited to see the kind of effects that it can have, the positive effects it can have in people's lives.
So that's fantastic. No, you know, I'm sure you know me well enough to know that I'm always advocating for a holistic approach. I think it's very, very important. I think that, like you said, a lot of different healthcare services will focus on the one problem and not really recognize that this one problem has a huge impact in so many different areas of your life. And in order to actually work through it, you actually need a holistic approach, because yes, it's great, let's fix this one problem, but then the person is still left with limitations and a whole new lifestyle that they have to adjust and become accustomed to, which nobody warns them about. It's just sort of like, yeah, we're going to fix you and then you're going to be okay, and then you have your surgery, and then it's like, oh, I can't do this now, and I can't do that now, and I can't do that now. And that process of discovering yourself and your limitations is really, really challenging. So I think more work like rehab consultation is desperately needed across the NHS, across all healthcare sectors. So thank you so much for joining us. Can you let us know a little bit more around the differences when you're treating patients with medical cannabis versus treating patients with conventional methods?
Yeah, absolutely. So, I actually like the fact that we're kind of really robust with cannabis. So, because it's still, I guess, relatively in its infancy in terms of prescribing practice in the UK, obviously it's only been available for about the last 6 years, and therefore it's very much a new thing in the UK, whereas other countries have got a bit of a head start on us. But because of that, it is still viewed, I think, by the wider medical fraternity with a bit of skepticism, which is in some ways is a good thing because it forces us to be really on point with our prescriptions. And one of the things I've noticed is that for considering that you are prescribing a single type of drug, our review systems are really really robust. So in the NHS, if you're prescribing an opioid, say, you don't have to sort of clear it with anybody else. You can just prescribe it on your own, and it's up to you however much you want to prescribe and what you think is appropriate. With cannabis, at least within the setup of the clinic that I am at, we do have an MDT approval process. So what happens is a consultant will see a new patient, but then all of our records will go off to at least two other doctors to make sure that they agree what we're doing is appropriate for that patient. And that includes looking through all the potential side effects, interactions with other medications, cautions and contraindications. Also, just making sure that the patient's appropriate from the point of view that they've done enough within their NHS services. And sometimes we do have to go back to patients and say, I'm really sorry, but there's a couple of the things that we're going to need you to try before we can start you. But I think most patients are really engaged with the process and they're happy to sort of go, actually, if this is better for me and more appropriate for me, I'm happy to do that. It might be that at some point in the future, the guidelines around cannabis prescription will change so that it wouldn't need to almost be the medication of last resort, but it might move a bit further up, I'm hoping, in our prescription guidelines, and hopefully then become a lot more widely available as well. But that's one of the things I really like about it, that actually for something that we're starting off with, we're kind of doing it slowly, carefully, but really, really robustly. We're just making absolutely sure this patient is appropriate for it. Because as much as I think a lot of patients don't like to talk about this, it's a medication like any other. It does have its side effects. It does have potential issues that it can cause. And that's why we keep a very close eye on these patients just to make sure that they're not getting any of the secondary side effects and just make sure that they're okay. So that I think would be the sort of biggest, most stark difference for one type of medication. There is a huge amount of caution, I think, around prescribing just to make sure that we're doing it safely.
Yeah. No, that's actually really interesting, actually, because I've never really thought about it in that context before. We're just so used to doing the process because obviously it's a schedule 2, so you have to be a lot more cautious with the medication than you would be with an opioid prescription, like you said. I mean, I know myself, I can just ask my GP for something, they just give it to me, obviously because they know I'm in chronic pain, they're not just gonna give it to anyone that asks. But I just meant in the sense that they don't have to go through a whole MDT process. Within 24 hours, it's at my pharmacy and I go and collect it. So I imagine that can also put barriers in place for patients because I know from my own experience, again, as a professional and as a patient, the length of time that you have to wait for a peer review, because obviously every patient has to be peer reviewed. So that can be very time consuming, especially if we need additional paperwork and stuff like that.
Yeah, and that I think that is an issue, and I only work at one clinic at present, so that I can't necessarily compare to others, but from what I've heard, it's an issue throughout the entire cannabis industry. And so that I think it's therefore incumbent on us as the healthcare professionals to try and sharpen up that stream and make sure that we get things done as promptly and quickly as possible for our patients. And that's a little bit of an issue, and I think something that we do need to work on. As I said, it might be that over time, as we gain more data about its side effects and so on, we might become more comfortable with it, and it might not need to be subjected to a peer review anymore. But for the time being, yeah, that's where it kind of sits. But if we think that that's the right thing to do for now because it is so nascent, then in that case, it is incumbent on us to make that process as fast and as smooth as possible. And we do try, but with the best will in the world, sometimes there are hiccups.
Yeah, no, but that's natural. And just in terms of comparing, sorry, the medications. So when you're I suppose when you're treating people at the NHS, you would treat people with a variety of different medications, whereas with medical cannabis, it's just a one medication. What are, I suppose, the benefits and maybe even some areas for improvements that you've recognized when using two different models of treatment in rehab consultancy?
Yeah, absolutely. So obviously there's quite a lot of medications that are available to you for both spasticity and pain, sort of seeing this from a rehab medicine consultant perspective. I've also come across a few patients who are using it for tremor with reasonably good effect. Um, and I think the big difference for me is again this the recognition of the harm that we can sometimes cause with sort of so-called traditional Western medications. One thing that I have learned over time is about the effects of withdrawing a lot of these medications, and this is a big issue that I hear a lot of the patients talking about, where you have been on codeine for a large amount of time and you really struggle to get off of it. And you think of codeine, it's not a big deal. We kind of, it's the next thing up in the pain scale, paracetamol, ibuprofen. Usually at that point, you go to codeine. But it's a really significant issue for some people, and they can become addicted quite easily. I had one patient tell me recently that it took him 8 years to get off of an opioid. And eventually, what he had to do was purchase his own scales and withdraw himself in in sort of really small doses at a time. It took him 8 years to do it because he just couldn't do it any other way. Every time he tried, he was failing. He was going back on it. It was causing severe rebound pain and sweating, all the other sort of withdrawal symptoms. So I think there needs to be a greater recognition of the damage that these things can do, that the fact that they're potentially addictive. And we probably need to warn patients about that a little bit more. We do a lot of warning of patients for the potential side effects of cannabis. And in fact, if I remember correctly, every time a script is sent out, there's a list, a warning list to say, look, if you've got any of these things, this is what you do, this is how you manage it, this is who you need to call. Um, and I think that's a really good idea, but we probably aren't quite so efficacious with a lot of the other medications. We don't necessarily do as much drug counseling as we should, I think, with a lot of them, especially things like pregabalin, gabapentin, or SNRIs, SSRIs. These medications can be very, very difficult to withdraw people from safely and not give them side effects. In fact, there are now some new deprescribing guidelines, relatively new deprescribing guidelines, and you'd be surprised. I was looking up what was it? It was duloxetine the other day in the deprescribing guidelines, and you're looking at 2 to 3 years to safely get somebody off of it. And that's quite a different thought process to what we usually do. We've often just gone, oh well, we sort of just reduce the dose over this many weeks, and then you go on to one every other day, and then you stop. But from the research that has been done and put into these guidelines, that's actually way too fast, and you will cause the majority of patients a lot of rebound problems by doing that. And it's not just duloxetine; it's the gabapentinoid medications, it's loads of other things that fall into that category. So I think my concern is about the risk that is entailed with withdrawing these medications, and with withdrawing from cannabis. If there is no psychological addiction, physically there doesn't seem to be much of a problem with people coming off of it. So I've had patients where they've said they haven't been able to get their medication again. We probably will talk about this, the bureaucracy around clinics and getting meds out. Yeah, we've had this chat, Berta. We've had this chat. Um,
I have not stopped complaining about it. I cannot, it's just horrific. I cannot roll my eyes any harder if I tried. I, yeah, go on. Sorry.
so bad. No, no, you're quite all right. I'm so on that page with you where you don't know what else to try. I have called clinics on patients' behalf, called dispensaries on patients' behalf rather, trying to chase it. prescriptions and medications, and just kind of feeling like you're not really getting anywhere and you're not really sure what else to try now. And sometimes I cancel it here and I send it there, and sort of the whole same thing happens again. So that's a real problem. But sorry, within the context of what I was saying before, I've got patients then who have an enforced tolerance break. And it might be, yeah, exactly. It might be 1 to 2 weeks at a time. And the difficulty with that is that if you were to do that with an opioid, if you were to stop it suddenly, you could really make somebody very, very ill. But that doesn't seem to happen with cannabis. There might be a psychological dependence in that they really don't like being away from their cannabis, but if it is stopped suddenly, they don't get sort of a rebound exacerbation of their pain. They feel it again, but it doesn't seem to rebound in the same way that you have with opioids. And I wonder if that's sort of to do with the fact that it does get sort of built up in your fat stores and then gradually released from there. So once you stop it, you still have some left in your body, and therefore you might still have a bit of background pain relief, but yeah, that's a little bit of an issue as well.
No, no, I mean, I'm sitting here and I'm just nodding my head because I'm in complete agreement. I know for myself, there's two things I wanted to touch on. The first thing is, yes, it does stay in your system. I tend to find that after about 10 days is when I start to really, really get the manifestation of all of my symptoms. But with a combination of yoga, heat patches, oils, rub eucalyptus, whatever, you know what I mean? CBD oil, you get everything on you, you can actually ride it out for about 10 days. And I tend to find the only thing that I get is the sweats. Like you get a bit of the sweats, like, and that's about it. Whereas I remember the very first time I was taking opioids, and that's the second point I wanted to get to, is that this is before I started working in substance misuse. So I knew nothing about substance misuse until I went into the field. And I was being prescribed, I think it was pregabalin. I think it was pregabalin, and yeah, nerve pain. Yeah, I think it was pregabalin, and they changed it to gabapentin. But anyways, I started on the pregabalin, and it was just making me very, very groggy. And I'm somebody who just likes to be compass mentis. So after a few days, I was like, I can't, like maybe a few weeks, maybe like 2 or 3 weeks. I was like, no, I can't, because I can't. Yeah, they kept telling me you're gonna get used to it, you're gonna get used to it, but I wasn't, because I've got a very sensitive nervous system, so everything hits me. So I said, okay, no, I'm just going to stop it. Now, I did not know that you can't just stop it. I did not know it was an opiate. Nobody told me it was an opiate. Nobody told me that you can't just abruptly stop the medication. So I felt violently ill. I felt like I had a flu, basically, flu-like symptoms, with like a stomach bug, like is what it felt like I had. And I remember, no, I think I had just started at the substance misuse place. Yeah, I had just started working as a practitioner, and one of my colleagues, I was complaining. I was like, I don't know why I feel so sick, and then he points out to me, "Didn't you just say you stopped taking this medication, pregabalin?" I was like, "Yeah." He goes, "You know that's an opiate, like you're withdrawing." I was like, "What?" I didn't even know. And then I went to my GP. Oh yeah, did no one tell you? No, nobody told me. Like no one told me, so I was dying for like a week. But I mean, the fortunate thing about opiates is that generally people feel like they're gonna die, but you don't actually die from withdrawal symptoms unless you have a heart condition or something, and then it causes a heart attack or something else like that. But it is still really, really important to have these conversations with your patients, because we don't know sometimes. Like we trust. Well, now I don't trust them, but before, you'd go in and you trust your doctor because you're like, that's my doctor, and they went to medical school, and I expect that they declared a Hippocratic oath, so I expect that they have my best intentions. Only to realize you're just part of a system and you're just ticking boxes. Which is really, really sad. But I'm going into another topic now, so I'm going to go back into rehab and medicine. So, what are some of the benefits that you found with patients other than not really withdrawing from medications? Did you feel, no, I don't really want to put stuff into your mouth, I suppose. What are the benefits you found? The feedback?
The big one I think for patients, and again you've just touched on this, is the fact that you don't necessarily get that brain fog with it. So it again, we're back to the whole sativa versus indica discussion, which I know is a massive hot plate. It's kind of an inferno at the minute, isn't it? No, some people are like, oh no, I don't really believe in the distinction, it's more about the terpenes. But I've found actually it does kind of matter some things in indica or sativa for most patients. So especially on the sativa type medications, you find that patients, they don't have brain fog, and in fact it helps them improve their focus. So obviously it's also used as an adjunct for ADHD patients, and they talk about this improved mental clarity and focus. And some days I think, oh, I could really use a sativa. I would just really like some. It's like, oh my goodness, my brain is shutting down. Somebody should give me something. But I love that aspect of it, because yeah, I've had patients have had to take back off of GABAergic meds or off of opioids or whatever because of the brain fog, because they can no longer function. And if you are a mother, a single mother with young kids, or a young professional like yourself, or you don't want to be in that situation where you are struggling to focus, and it feels like marshaling your thoughts is a massive expenditure of energy. I mean, for most of the conditions that we're managing, you already have limited energy. The last thing you want to do is then have your brain soaking up even more, just because you're trying to have coherent thoughts and keep your mind together. So for me, that's been a very, very big one, a massive advantage. In fact, the other thing I'll touch on was, even from before I kind of officially started, when I was still doing my onboarding, I remember sitting in with one doctor who saw a patient who was reporting back on the positive effects in his life. And he was talking about, before his pain and his issues were in such a place that he was almost on the verge of splitting up with his partner. He didn't have energy for his kids. He didn't want to know. He wasn't going out. He wasn't socializing. He wasn't able to work. Fast forward a few months into management with a CBMP, and it was just amazing, the difference in him, the fact that he is now back out to work. So he's now financially independent again. He's now putting something back into the tax system. So the government should be really happy to hear about stuff like this. You would think so. And then he's going out and spending that money as well. So he's now socializing. He's seeing his friends again. So he's got that very, very important network of people around him that he are invested in him, and he in them. I don't know if everybody realizes how very, very isolating it is to be stuck in the house when you can't go out. But with the best will in the world, most friendships will die a death if you can't maintain them by meeting up every so often. And therefore, I think especially for men, because we'll sit down on the phone and talk for like hours, wouldn't we? Us girls. Apologies if that sounds sexist, but as a general rule, my experience around blokes is that they tend to meet up. They go out for a drink, or they go and watch a game or something like that. They do something where they actually are face to face. So they being able to maintain those friendships was just so critical, and also an improved relationship with his kids. Now he has time for them. He has energy with them. It's no longer, why is daddy in the bedroom, with the light off and just doped up on medicines. He's now actually able to interact with them. So it's not just even just him, but the positive memories that are going to be reinforced with his kids, which will have a long lasting impact on their relationship and how they relate to each other in future years. That's massive, and cannot be downplayed. Where you're saying, actually, if again you look at the entire person and say, if we can just change this one factor about your life, what is the impact? What's going to be the overspill into everything else? And for him, it was night and day. I see patients with inflammatory bowel diseases as well. Not typically as part of my specialty, but I've come to take on a few of them as legacy patients and so on. And again, you're talking about somebody who might go from having to keep their eye on the toilet at all times, because and that's a horrible way to live, where you're going from one location to the other. The first thing that you locate is the toilet. You're on a plane and they're pointing out the exits, and you're looking for the toilet, because that's the only thing you can think of. Because what happens happens if I need to go urgently? And if I can, if then that urgency is reduced by even just half, then that makes journeys a lot more tolerable, a lot more possible, a lot more comfortable. And you do see patients sort of have this complete about face sometimes in their lives, in their existences. It's for me, it's just incredible.
No, it's amazing. And do you know what? I love the airplane analogy, because I think that accurately describes anybody who has got some kind of a long-term illness, whether it's IBS, whether it's chronic pain, whether it's mental health, right? You get to a point in your life where you're actually scared to leave the house because you don't know what symptoms will manifest that day and if you're going to be able to manage it, which is a really scary way of living. I know for myself, there was a period where when I was really, really ill, I developed a bit of agoraphobia because I was so scared that at any moment, and I meant any moment, I could faint. At any moment, my body would seize up and I wouldn't be able to move and I would collapse, or the left side of my body would go completely paralyzed and I would just fall out. It still happens now, but not in the same frequency as it was happening then. And so, after trying to get to work and fainting in Oxford Circus tube station, trying to get out of tube, I was like, right, yeah, I'm done leaving the house now. And it was really, yeah. No, but it was like, I'm glad I can laugh about it now. But at the time, it was a really, really scary experience. And it got to a point where even when I was going towards the door, like if I had a hospital appointment I needed to attend, I would be having a panic attack at least for 15 minutes before I could leave the house. And I'd have to really just be like, Bertol, you need to go and see the doctor. You're not going to get any better. You have to go to your appointment. If you faint, you faint. It's fine. Like, just, yeah, but yeah, just, yeah, yeah, it's like that. But the thing is, though, there's a reason why I wanted to highlight it, because a lot of the times people, they don't really recognize all the different parts of your life that is impacted, including your mental health as well. When I'm talking about somebody with a chronic illness that isn't mental health, it does impact your mental health as well. Not just because of the correlation between pain and your mental health and your physical health. Like, I know that the pain receptors are the same. So if you feel physical pain, you're bound to feel emotional pain as well. But it's not just because of that, it's because of the limitations, the barriers, the fear. It really makes it difficult to even want to live a life. Um, yeah, you just want to stay in your bed all of the time. So hearing that and how somebody is getting 50% relief, I get about 75% relief, like from my symptoms and pain. And it's just amazing. And it breaks my heart when I think about people not being on the medication, still living in that fear because of another fear, which is being judged for using a medical cannabis prescription.
Yeah, that unfortunately, and that's still a massive issue, isn't it? The stigma that is associated with it. It's funny because I've been saying to a lot of my patients on their first appointments, just relax. This is just a normal conversation. I'm just going to have a chat with you about your symptoms, and what I want to do is make sure that you're safe to take this. This is not a judgmental thing at all. But so many of them, they you can almost see them sort of tensing when they start to say, oh well, they've already tried taking cannabis. I kind of go, but you're in a desperate situation where you've tried so many different things and they haven't worked, and or they've had really negative side effects, and you just thought, I've got to try something, and this is the thing that's worked the best for you. So you got to remember, if you're coming to a clinic for the first time, there is not going to be a judgment if you've already started using cannabis on the black market. As much as we would usually discourage that, there's no judgment around it, because I think most of us can sympathize with somebody who's at the end of their tether and is just desperate to get something changed. In that case, I would say, please seek out a legal cannabis clinic rather rather than going down the black market route. Because the other thing that we will do is we will make sure that it's safe and it's appropriate for you, and then proceed from there. But yeah, it's trying to let people know, we don't think of you as a bad person because you got something for pain. That doesn't make you bad. That makes you human.
Yeah. Yeah, well, you can't tolerate something anymore, then fair enough. Like, um, and so just to sort of like round it off, then, what sort of advice would you give cannabis naive patients who are considering a prescription? And no, I'll ask the second question after.
Okay, if you've never tried cannabis before, again, yeah, I would rather you didn't go down the black market route. It is very difficult to identify exactly what you're getting, one, and two, you're not looked on with a lot of favor if you come into contact with the police, and you can get into a bit of trouble and a bit of difficulty there. It's much better if you come and get it medically prescribed because, as I said, we just make sure that it's safe and it's appropriate for you, and we try and tailor the particular flower or oil or vape that we give you to your specific symptoms and what's happening with you. Also, just don't be terrified. You're going to find that most of us working in this side of medicine, we're sort of a little bit different, and that's just from the point of view that we've seen what the other medications have to offer and we didn't really like it. So we've come here. We want to prescribe something that's hopefully not going to necessarily have the same effects that we were talking about earlier. So we want you to come. We want to see you. We want to help you. We really want to do right by you. So do come, booking an appointment, and let's try and get you sorted.
Yeah, and like you said, that clinical input is so, so important because if you go to the illicit market, yes, there's so many other dangers involved. But for me, it's always been the fact that you're still not managing your condition. You're just masking it. Like, whereas when you come to a clinic, you have a clinical input and you look at other areas that you can improve on and different things that you can do. And like I said earlier, you look at a more holistic approach to your care. So yeah, the clinical input is really important. And so, what advice would you give to the industry now, the medical cannabis community?
Okay, the first thing we need to do is sort out the supply chain. It's like the most massive thing ever. When you are in a clinic and you are prescribing, and at the end of the day, you get a message to say we're really sorry, but we're now out of stock of XYZ, and you've been prescribing it all day. You just think, right, I'm gonna have to just like redo everything. Clearly have to contact everybody and redo all the prescriptions and so on. And it's happened to me before where I've prescribed an alternative, only then for the alternative to go out of stock. So it is a massive issue. The other thing is around the naming of meds. So my one of my requests would be if you've got a medication with a particular name, please don't apply that name to anything else. There's one particular flower I'm thinking of which has come out in four different iterations with four different strengths of THC. So if a patient tells me that they've had XYZ before, I'm like, but which one? I don't know. I don't want to underdose you or overdose you. So it's kind of important that we standardize things a little bit better. And please, please don't take everything off of the market just because it's low THC. There are a lot of patients that are reliant on lower THC medications. Please don't take all the lower THC stuff off because we need it.
Do you know what? Yeah, I'm actually going to comment on that as well. The lower THC one. I mean, I've complained enough about supply chain on this podcast that I think everybody knows what my position on that is. So that stuff it's kind of not fair as well. There's so many variables involved. But it's still annoying. But yeah, one of the things I hate is when they start discontinuing medication either because it's low strain or I have no idea why. I mean, Night Queen till today, I am complaining that Night Queen has been discontinued, and so are several other patients that I know that are also complaining about Night Queen because it was an amazing medication. I have no idea why it was discontinued. Until today, we have not been able to find any nighttime medication that works as well as Night Queen does. So please stop discontinuing good medication. Also, I tend to find the lower THC strains work so much better for my pain than the higher ones. Like sometimes, of course, when I'm in like 10 out of 10, yeah, I do need a higher one. But when I'm at like 6, 7, 8, and I need something, I tend to find the lower ones actually work so much better for me. then the higher strain. I don't know why, because I know for other people it's the opposite way around. But there are some anomalies like myself who prefer lower strain and can function better mentally with a lower strain. Exactly, exactly. So please don't mess with our medication. But no, but no, thank you so much for coming on. It was absolutely fantastic to hear about your work and everything that you're doing. And I really, really hope that it's going to encourage a lot of people to look at their well-being from a holistic approach and understand that medication, it is after all just medication. You do need to put the work in to managing your well-being and physical health.
And I'll say this one last thing in terms of people sort of naysaying about cannabis. One of the things that I've heard is, oh well, there are all these potential psychological side effects. And it's like, well, have you read the bucket list of side effects that come around with any other medication? um why do we have sort of, so I or it's available on the black market, we shouldn't be prescribing black, but we have heroin is an opioid. That's not stopped anybody from prescribing fentanyl yet, just because heroin exists. So maybe we need to have some more logical thinking about these things. And the other point I would make is, I once heard somebody say, well, it's not a true painkiller, it only puts the pain to one side so that you can function. And I was like, well, isn't that a painkiller? That's what you want. You want to be able to function. So that, yes, the pain isn't gone, but in some cases that's actually probably better, because you want to be able to monitor what your condition is like. So if the pain is still very severe, but you don't have the emotional response to it, at least you still know that it's there. And it's still acting as that warning signal for you that there might be something going on. You might need to go and see your specialist and get checked out for your condition again. So I don't know that that's a reason to not prescribe it. But that's just my 2 cents worth.
That's first of all amazing, and I think we're actually going to leave it there because let's let people. No, let that sink in with people. Thank you so much for having us. Thank you so much for coming on today. Everyone, thank you for joining us. And we look forward to seeing you next week where we're going to explore patient experiences. Thank you.
Fantastic. Nice to see you, Berta. Take care.
Thanks. Bye.